Let me start by reminding folks, I often, when I give this presentation or one like it, I always have someone from a different political persuasion, i.e. a non-physician, come up to me and say, why do I feel so strongly about this? And I remind them that I'm a doctor. I'm supposed to do this, okay? I am supposed to get up every morning. I'm supposed to get up every morning and exercise and eat better and lose weight. But I'm also supposed to get up and argue vigorously for your and my health, okay? This is not a political presentation. This is the right thing to do for our national well-being. So what I'm going to talk with you today about is a bit about the Affordable Care Act, but from my perspective, what it means from a public health perspective, and some of the things I think that we need to be doing as we move forward in trying to both, in my view, implement this legislation, which frankly is now the law of the land, but also opportunity to try to improve our systems, our public health systems, in a way that hopefully makes some sense and move this agenda forward. Now, I always argue that some things are just true, and some of you may know this comedian. This is Moms Mabley. And those of you who are of my age and older remember, at least in my household, this is the time when you took these records and you snuck in the basement and listened to them because your parents really wouldn't let you listen to these up in the living room. So you snuck in the basement to listen to Moms. Moms often said things that could not be said in polite company, okay? But this is something she said that says have enormous wisdom. If you always do what you always did, then you'll always get what you always got. And think about that. That's why we did health reform, okay? Let's ask ourselves fundamentally what we always got under the system that we have today. We had a system whose costs were rising at a rate which was unsustainable, uncontrollable, gobbling up over 16% of a gross domestic product, almost twice of what any other industrialized nation of the world, which all have universal health care, I might add, which we still have not achieved, at an affordable rate. In addition, it was unaffordable for most Americans. This is not necessarily unaffordable for poor people. They were always challenged, although really poor people, at least many poor women and children in most states, had some safety net coverage. Many single adults did not, who were poor, or low-income workers were poor. But now the middle class were finding themselves increasingly unable to afford health care. In fact, the leading cause of individual bankruptcies in this country is health care costs. Last time I checked, bankruptcy was an economic issue. So that firmly links resolving the health care cost crisis as an economic crisis and essential to our economic well-being as a nation. Secondly, quality and safety concerns. We have the best care in the world if you can A, get in it, and B, nothing goes wrong. And I don't care where you are. If you're in the best system in this state or the best system in any other state, things go wrong. And they go wrong because, unlike the airline industry, the medical industrial complex, the healthcare industrial complex, has not figured out that checklists work and that automated electronic medical records and data systems and actually having information to make decisions is a good way to practice health and medical care. You know, until you can go into a system and reliably and consistently be assured of what the outcome will be, Even if it's a bad outcome, you can't begin to improve the system. And so over 100,000 people in our country die every year from medical errors, which are preventable in most cases. Preventable in most cases. We have extraordinary disparities in health outcomes. You just saw that from your Healthy People 2020 presentation. And this is a significant problem in our system. And I can't understand why anyone in the world, you know, the big debate about medical effectiveness research, why would anyone in the world want to pay for something that does not work? Explain to me why anyone would pay to have something fixed the second time that wasn't fixed right the first time. Why would we do that? It makes no sense. And yet we continue to perpetuate that in our systems and what we pay and the service deliveries in which we give. We have a growing number of people who are both uninsured and underinsured. Over 50 million people are uninsured and underinsured, but you know, at any one point in time, that number can be almost twice that. People who are uninsured or underinsured for brief periods of time. And I got to tell you, one of the privileges of this job is I get to travel both in the United States and I get to travel outside the United States. And I don't worry about money. I mean, I don't have that much. But for what I do have, I got a wonderful thing called an ATM card. And whether I'm in Israel or Brazil or Jamaica, or my favorite place, Aruba, or Washington, D.C., realizing, boy, I can get some money to go, you know, to go in this restaurant, I can go to an ATM and get money out 24 hours a day, 7 days a week, assuming the machine is working. But if I get injured or fall down sick right here in North Carolina, there is no way you can get my electrocardiogram or any part of my medical record because it's not available, it's not online. I can track a FedEx package anywhere around the globe at 3 o'clock in the morning, and yet I cannot tell you what my CBC or my last blood sugar or what my cholesterol level was. My doctor can't get it, the ER doctor can't get it, none of you can get it, nor can any of the reporters who want to find out about my medical history get it. Okay? They shouldn't be able to get it. We have to secure our medical records, but we don't have a health IT system that makes any sense. Okay? Doesn't make any sense at all. And I think the most important thing for me is that we know that prevention works and yet we don't use it. We've got a system that is much more interested in spending money on the back end when we can do things and spend much less money on the front end. And we argue vigorously about whether prevention saves money. Well, we don't argue vigorously about whether open heart surgery saves money, or if we fix someone up after a gunshot wound, whether that saves money, or whether or not if somebody falls and breaks their hip, whether that saves money. And yet, if we decide we want to vaccinate people, we have to prove that it saves money before we're willing to spend money on it. Doesn't make any sense. So, in many ways, the debate on healthcare reform was trying to fix a host of problems about which are major, overwhelming, and hopefully, while not perfect, the legislation moves us a long, long way towards trying to rationalize our system in a meaningful way. You notice I didn't say ration services. I said rationalize the system. Make it make some sense so I don't have to spend money for things I don't want to spend money for and have better health care on the other end. Now, I happen to believe it was a major health policy achievement. It achieves at least 90% of health care coverage, assuming everything works, everyone gets in the system. It has major insurance reforms that affect everybody. This legislation does actively promote prevention and wellness. We're going to talk primarily about that. It begins to actively promote primary care. If done right, it will increase value and quality for our health care dollar. The way Congress counts, it reduces the deficit by $143 billion. And I understand there are some in Washington that want to change the accounting mechanisms now. which is fine with me. If they change the accounting mechanisms the way I would like to change them, then we can afford to cover the other 23 million people that are uncovered. But nonetheless, we believe it does reduce the deficit. It increases affordability for many, many, many people in this system. And it supports a modern health information technology system. But of course, it has some implementation challenges. You know, when you expand insurance coverage, one of the very clear things we know is that having an insurance card does not equal access to care. And there's a dramatic need for actually increasing the safety net. One of the things in Massachusetts that those federally qualified health centers suddenly discovered was they had more patients. Their volume actually went up. Many of the safety net systems' volume actually went up. The patients that they already had, of course, now had an insurance card and could pay for some of their care, so they came in for the care that they needed. And the safety net system is, of course, still there to catch people that fall through the cracks, and needs to provide services to expanding populations. So many of you, as you go through your legislative sessions, your legislators, particularly at the local level, will now say, well, we really don't necessarily need this public health service or that public health service, but the fact of the matter is they now need you more than ever as a way of trying to provide an effective safety net. And that does mean we're going to have to reinforce, adjust, and remodel every single core public health program that we have. It's all going to change. And I'm going to share a couple of examples with you in a moment. And of course, we have to implement a fair number of new programs that this law empowers. Now, it is, of course, a challenge because doing this in a recession, well, I like to say hopefully we're in recovery now, is a challenge because the states all are under financial stress. No question about that. The federal budgets are challenged, and we always have more needs than money. We've got hiring freezes, we've got training reductions. You know, you can't travel to go here, you can't travel to go there. Training's always the first thing to go. But what you need under this kind of system where you're changing, you need more training, you need more education for your staff. There are many, many other urgent priorities that occur. In some states, there are legislative requirements. If you're one of these states where your legislature only meets every 2 years, trying to use some of the dollars that are available are a challenge for you. Because in some states, those dollars actually have to be appropriated by the legislature. And of course, we all know that the history of public health funding is what I call yo-yo funding. It's where they give you the money, we almost get the problem under control, and then they cut the money. The problem comes back with a vengeance, and then we spend more money and equal opportunity, funding opportunity, and program opportunity for programs that we almost got our hands around because we don't think about things, you know, for the long term. And we also have this big challenge of supplantation. Despite the fact that there's language in the bill to fundamentally base everything at the 2008 level, legislators are very, very good. Resource allocators are very, very good at figuring out how to supplant things at the federal, state, and local level. So we have to make sure that we challenge that as we go forward. And I think that fundamentally what this bill means, this law, is that our policy development, assessment, and indirect insurance roles will all increase. Our service delivery roles will probably decrease, and depending on where you are, they may decrease a lot. If you're in a state that decides to fully embrace this and go and try to get everyone covered, et cetera, your coverage role is definitely going to decrease. And there's a need for us, as I said, to remodel all these programs. Again, this is just a short list of some of the programs that we've thought about at APHA need to be remodeled. And of course, my goal is for us to capture and reapply the savings. So if we get our hands around this, if we understand what changes are going to occur, then we can go to our resource allocators and say, hey, yes, this program is going to change some. Yes, we may not need to spend as much money here in this program the way we designed it today, but we want to take that money and we want to move it around to do something new that we think will be more effective in a meaningful way. Now let's talk about the first population-based issue that they did, the coverage issue. It does cover 32 million more non-elderly people. Let me remind you, in the big debate about the fact that government funding for health care whose patients these were to begin with. They were ours, okay? They were already in the governmental system. All the debate about doctors worrying about, private doctors worrying about their offices being inundated, they weren't worried about that when there was no money on the table, right? They were our patients to begin with. They were just being seen in the most inefficient manner possible in our siloed public health programs, in the emergency departments, in private doctors' offices, who were, quite frankly, and appropriately, providing care to them pro bono, and we thank all of our medical colleagues for doing that. But it was often inefficient. It was also inefficient. It was often first come, first served. So let's remember who the patients we're talking about are to begin with. And in some cases, of course, they were nobody's patients. In many cases, that they came in and out of the system in a much more uncoordinated way, particularly for those patients. Now, the goal is to raise Medicaid up to 133% of the federal poverty level, which gets you up to somewhere around $29,000 for a family of four. That ain't a lot of money. And even more interestingly enough, which often doesn't get talked about, we got rid of all the silos. Remember all the categorical silos we had for Medicaid? Those are all gone now. If you simply had 133% of the federal poverty level, you're in. So all those people that used to rotate in and out of the Medicaid program because they got a job that paid them $15 more a week than the job they had last week, that got dumped off the program every now and then, that's gone. That's gone. That revolving door will happen now at 133% of the federal poverty level, okay? But not at a much lower level. All those single individuals that used to be in your mental health programs and in your substance abuse programs, and then if you had a primary care program and they're below 133% of the federal poverty level, they're all going to have a primary care doctor. That means you can sit down and figure out how best to provide them comprehensive, good primary care. All those people that you had trouble finding specialists for, that were at 120% of the federal poverty level, for better or for worse, they'll be in the Medicaid program. Now, there's some challenges around that, but that's going to be important. Also, by the way, they're going to pay Medicaid practitioners for primary care at Medicare rates. So they're going to enhance, at least for 2 years, the physician reimbursement for primary care services at the Medicare rate. So you won't have that disparity between Medicare and Medicaid for primary care services, and pediatrics and internal medicine and family practice pretty much are in that bucket, as a way of trying to make sure that we have people that want to take Medicaid patients. And then what we've done is we've taken our tax dollars, yes, we've taken our tax dollars, and we've decided that we're going to supplement the coverage of people under 400% of the federal poverty level, so they can afford coverage. And those tend to be the people that, if you stayed in this hotel, I don't know if this hotel offers health benefits, but many hotels don't, particularly those that are not unionized, offers them health benefits. They'll be able to buy into one of those health exchanges to get health benefits, and we're going to subsidize them because we think, as a nation, there's a value in doing so, in ensuring that they have health coverage. And then they've done some things around Medicare, such as getting rid of the Medicare, the donut hole. So people with high-cost prescription coverage will now be able to not have this fear of hitting that donut hole and suddenly having to pay out of pocket large amounts of money to pay for their prescription coverage. New care coordination benefits, actually going to ask Medicare doctors to coordinate care and make sure the systems make sense for people with chronic diseases. Imagine, just have this vision of the pulmonologists and the cardiologists and endocrinologists talking to one another. Imagine what a revolutionary idea that would be. And yeah, it sounds a little, I'm being facetious. Absolutely. Absolutely. But creating incentives, fiscal incentives, system incentives for those systems to actually happen. For the hospital and the nursing home and the primary care docs to have a system which requires that they talk to one another. Okay? That's what we're talking about. And then a new prevention benefit. Well, it was interesting, you know, Medicare was a treatment benefit. And when those of us who were fighting to get influenza vaccination into the Medicare program, you know, that had to go through Congress. Congress had to approve each and every prevention benefit that went into the Medicare program. That meant that Congress and all of its political parties had to demonstrate a willingness to work and play well together to pass each and every benefit, and the Congressional Budget Office had to score it in such a way that there was a savings through the prevention benefit in order to put it in there. Okay? So now, if it's evidence-based, we use it. If it's not evidence-based, you know, the insurance companies can still offer it, but we don't necessarily have to have that in the plan unless it's evidence-based. It also expands the safety net. It creates a fair amount of money for community health centers. The Bush administration was very good, put $100 million into community health centers. During their administration, this initiative expands that effort to try to put $10 billion over 5 years to try to enhance community health systems through these centers. Hopefully this will allow for rehabilitation of those federally qualified health centers and maybe some new federally qualified health centers to come up to speed in terms of their capital needs. Also, it authorizes some capital expenditures for community health centers, school-based health centers, in primarily underserved communities. So there's an investment here to try to really do some capital work. Oh, and by the way, the last time I checked, dollars that go for capital expenditures generally go out to the community and create an enormous amount of jobs as part of that process. In fact, it's often been said, one of the reasons that your elected officials support construction projects, other than the fact that you can put people's names on the buildings, construction projects, because the number of times a dollar revolves in the community and the economic development aspects of that, which are wonderful. Fiscal aspects of coverage are a challenge, though. Remind you that the fact that if you bill and collect in your systems, as we transition to this system, some of you may need to now, who weren't billing and collecting, may now need to bill and collect, and there's a big steep learning curve in that. Or you may need to enhance your billing and collecting services, because people are now going to come in with an insurance card for something which you may have provided under a grant before, and you have to rethink about that. You're still going to have uncompensated services. One of the things we've learned in Maryland when we did our Medicaid managed care, that simply going from a grant to fee-for-service is not a smooth encounter. So you're going to have to think about that. And in many cases, the revenue streams don't come back to you, they go back to the general fund. So sometimes the incentive for the public health community to bill and collect isn't there because we don't get the money back. So you're going to have to sit down and figure out what that means in terms of your budgeting and fiscal processes. There's also potential to decrease revenue from grants and contracts because clearly some of our grants are based on the number of uninsured people you have. We're going to talk about that in just a moment as well. Now, in Maryland, this will give you an example. In Maryland, we have all of these pharmacy programs. We have a very vast pharmacy assistance program, and every one of those programs that we have in Maryland is going to have to change now. Maryland's one of these states that's going to aggressively implement the Affordable Care Act. Their governor's gotten together. They've shown that they're going to save a whole lot of money by doing this. Maryland's a state that had really invested in covering people over the last several years. And so they're going to actually benefit to the tune of several $100 million over the next 10 years because of this legislation. But there are some programs that Maryland has for pharmacy assistance that are going to have to change. We're going to have to sit down and figure out now who's eligible, who isn't eligible, what are the gaps in our programs as we go forward. Jeff mentioned the point that the prevention and wellness services now as part of the essential health benefit for all of those plans that are going to go into the health exchanges, for Medicare in particular, and as an optional service for Medicaid. I don't know why they didn't mandate it under Medicaid, but they made it an optional service to allow, to require the use of evidence-based prevention services in all their plans, and first dollar coverage, which is going to be important as people go to get their various services. I'd like to point out that there's all kinds of language in this legislation which authorizes interesting things. So a study for the Government Accounting Office to look at actually how the Medicare Part D prescription drug program is working. One of the things that I thought is neat, the fact that they actually authorize a demonstration program for adult immunization coverage. You know, we've never had a robust adult immunization program in this country, but so there's an effort here for us to begin a pilot project to look at the appropriateness of all the adult vaccines and figure out how best to do that as we move forward. There were some things that got reauthorized, like the 317 vaccine program. Actually formally got reauthorized as part of it. It had to be reauthorized anyway, but it got reauthorized as part of this process. And if you're one of these states that wants to buy off the federal vaccine process, it authorizes all states to be able to do this. Now, one of my favorite programs is the Vaccine for Children's program. As you know, this program provides vaccines for underage, underinsured and uninsured children. It's a good program. It's been the crux of our national vaccine and immunization effort. And again, I noticed in your 2020 objectives that this is a very, very important objective for you in terms of improving vaccine coverage. And it will change in the environment in which everybody has coverage, particularly all the kids get coverage. So now you have some states like Maryland where we've outsourced all the vaccinations. All the immunizations are given out in the private sector in Maryland. Maryland stands back as a regulator and looks at who's getting their shots and works with the private docs to make sure they get their shots. There are some states where the health department provides an awful lot of the vaccinations, even for insured children. And they often do that without charging those children. That's probably going to change. You're either going to probably have to put them out to the private sector, or you're going to probably have to bill for that service. I doubt that the feds are going to continue to fund that at any particular level. And that's something you need to get your hands around, depending on how you run your vaccine programs. And that, of course, has all kinds of implications around staffing and facilities and funding, et cetera, and maybe the viability of that grant. So that's something folks need to pay a lot of attention to pretty soon, because, again, the kids part of this is probably going to continue at some level no matter what happens. The impact of the breast and cervical cancer program. Lessons from Massachusetts. As you know, this is a very, very important program. Covers women up to 250% of the federal poverty level. No first dollar coverage, no barrier. Woman decides who's in this income category decides she wants to get her annual mammography screen or her cervical screen. It also does some other things. She can just go in, make an appointment, go in, be seen. No, doesn't cost her anything. Woman feels she has a breast lump, again, is eligible for this program. She can go in, she can be seen, no barrier to getting seen. There are many states which this program works extraordinarily well. It provides wraparound services. It helps link these women to specialty care. And if they're found to have a cancer on their biopsy, it will allow them to go in the Medicaid program as a categorical eligible. Now, having said that, for this program, imagine now you're a woman who's between 250% of the federal poverty level and 400% of the federal poverty level. Okay? I'm sorry, you're above 133% of the federal poverty level and 40% of the federal poverty level. Okay? You're going to, you may fall into a category in which you may have been eligible for this program, you're now being seen, you now got an insurance card, and now you're going to see your primary care doctor. Well, you didn't have a co-payment when you were going through the breast and cervical cancer program, but you might have one to actually see your primary care doctor. So we have to work some of those things out to make sure those women actually get seen. Theoretically, if they're below 250, they should still be able to be seen by this program, but we're going to have to kind of work this out. It's primarily for uninsured or underinsured women. So the question is whether they're eligible for the program or not. Massachusetts, by the way, has had this problem already. They had to sit down with CDC and figure out how to make this transition in this very, very important program. And the other thing that happens is that part of the program, as you know, it has some restrictions on how much you can spend on care, how much you can spend on wraparound services, et cetera. And so this is something you ought to sit down and ask yourself, how does this program change in an environment in which everybody has an insurance card? You know, who's not covered in our catchment area? What are our patients? It may not change at all, but it may change a lot. And it's something you want to think about and you want to get ahead of early. One of the important things in the legislation was the National Prevention, Health Promotion, and Public Health Council, headed by the Surgeon General. This is a task force of cabinet-level officials, headed by the Surgeon General, to craft a national strategy on prevention and wellness, to coordinate federal efforts, and to move our nation towards a prevention and wellness strategy. And we think this is a very, very important part of the law. Last spring, this council put out these principles. You note the heavy emphasis on prevention, wellness, and public health. Note the emphasis on health equity. Note the emphasis on alignment between the public and private sector activities. And notice the emphasis on ensuring accountability, measuring what we do. And of course, North Carolina has been one of the leaders in accountability through your accreditations process. And obviously, this is a nod to what you're doing there. Also note that they put out these 5 strategies, these strategies on how to address prevention and wellness. So you have a strategy which talks about policy and systems change, a strategy which talks about making environmental changes, working with program and service delivery, and trying to communicate much better as a way of a strategy of improving prevention and public health throughout our nation. And they looked at least in their initial report, these leading causes of diseases, premature death and disability, and focus on these behaviors. And all of these behaviors are things that you've captured. In fact, these diseases are all things that you've captured in your Healthy People 2020 activity. This new report, by the way, is going to come out the next month or so. And we're eagerly looking, because it's a much more vigorous look at where they think that we ought to take the nation. There's also funding in there, which is mandatory appropriation funding. I want everyone to understand what that means. That means that it has to happen every year, whether Congress approves an appropriations bill or not. As long as the government is working, i.e. a continuing resolution goes on that says, yep, we're going to fund the government, this has to happen. It eventually ramps up to $2 billion a year, and it doesn't end at 2014, 2015. This goes on forever. And it's built up as an attempt to try to build public health at a $2 billion level above the 2008 appropriations level. And it was an attempt to try to actually put a boost at creating some sustainable funding level for public health. And one of the ways they're going to use that fund, one of the authorizations in that fund are these community transformation grants. These have not been awarded yet. They've not really done the processes to really get these out the door. But just know that these grants are designed to really fundamentally change the way we approach public health from a much more holistic way, looking at healthier school environments and access to nutritious foods, and changing some of the core social determinants of health that we know are important to try and improving health in our communities. When these grants happen, these are going to be very, very important tools for us to try to improve the health of our communities. Now, the first $250 million of this that went out for a range of programs. This kind of gives you a list of some of those programs. I want to point out a couple here. There's $70 million that went out for public health infrastructure, and the public health training dollars, $23 million that went out. I want to point these out because These are dollars that went to the communities to actually help us support our public health infrastructure and our education processes for the public health workforce. And you'll hear legislators talk about this fund being a slush fund, and this fund being for jungle gyms. Now, I happen to think jungle gyms are good, and I think that way because I think communities that have good parks and recreations and activities for kids have less kids that get in trouble. They cost the healthcare system less, and they perform better in school. But you know, I'm just following the science. The fact is that this $250 million that went out for public health and the $750 million that HHS is just about to announce is going for good things that will support a range of very, very important community-based public health activities. That $126 million went out to community groups, went out to health departments, went out to coalitions in the community to improve the health of the community. You know, these aren't government bureaucrats spending this money. These are your neighbors that got those grants. This is the YMCA. This is the Red Cross. This is the Parks and Recreation Division. This is the various state and local health departments in our nation that got these dollars. So when people talk about this money being a slush fund and not knowing what the money is for, I don't understand what they're talking about. Now, we were not excited about the second $250 million that went out the door. They took $250 million, half of the first part of this funding, and did it for primary care. Now, we weren't excited about this. We thought that this should come out of some other fund. But look at where it went. It went primarily to public health practitioners, primary care practitioners. And I remind people that this is the workforce in which we steal most of our public health practitioners from. So in many ways, it did help us. But when folks say it's not going to do anything useful, this is going to actually help build the primary care workforce, which we know is desperately needed in our country. So this was also very important. There was some language in there about nutritional labeling of food items, which requires restaurants with 20 or more locations doing business under the same name to require them to do nutritional labeling. We think this is going to be good. We think at point of purchase, it's important for people to be able to identify what foods they have. There is a National Workforce Commission, which although it's not been funded, public health is in the workforce's charge. This is going to begin looking at the needs of the health workforce. I'm concerned about this as I get older. I'm very concerned about the workforce and who's going to take care of me as I get older, who's going to take care of my kids as they grow up. So I care a lot about this workforce issue as it goes forward. There is a authorization for public health workforce loan repayment. So if you're going to go to school and then go back into public health, there's an opportunity for you to be incentivized to do that. This has not yet been funded, but we're hoping in the next allocation of funding from HHS that they will actually put that in there. And there's a range of other kinds. There's something in there for oral health, and there's some other programs in for a range of other types of health professionals, many of which do core public health as part of what they do, some oral health efforts that are in there as well. So we think this is a good piece of the law that needs to be funded. It fundamentally authorizes CDC to do prevention research, to ask the important questions, particularly around transitional research that needs to occur. This is very, very important, and we're hopefully CDC will get up and running on this effort as it goes forward. There's a requirement to eliminate health disparities. It codifies the Offices of Minority Health and all of the various HHS agencies, as well as moves the Office of Minority Health within HHS, so it's a direct report to the Secretary. It also requires that we gather the data. We were talking about data at various levels. It requires that we gather data at the lowest geographical areas possible around a whole range of data points. It requires a national strategy to address quality in health care. And that's going to be very important. You here in North Carolina have already way ahead of the nation in many of these efforts. This is just a big chart to show you that, because I often get asked by people, they tell me that public health doesn't have a quality effort. And so we drew this graph up to show people that we have a very robust quality effort, quality infrastructure. We have all the same stuff that the medical care folks have, plus we got a whole lot of other stuff, including the National Board of Public Health Examiners, the Public Health Accreditation Board, the Council on Education and Public Health, which, certifies the schools of public health. We have a very, very vast quality effort in public health, which addresses both individual health and population health. This is just to show you that if we take all the 10 essential services, that we have a range of tools, of activities in the quality arena which supports the 10 essential services. Our quality activities are vast. If anyone tells you we don't have it, send them to me. We have a very, very vast quality effort in terms of accountability. We have a lot of tools for accountability. We just need to use them a little bit better. We need to shout at and tell people that we have them, because people just don't know. Because I often get asked, how do you know that public health works? All right? And we just haven't taken that message and we show people that we measure things all the time. We know what we do. We just need to promote it a lot better. And yes, we have to be accountable. We have to be regulators. We have to be change agents. As you know, the Robert Wood Johnson Foundation and NATIO now have this state-by-state ranking of counties, which I think is very important, will help you make some decisions as you go forward. I already gave a shout out to the Public Health Accreditation Board. APHA, the Partnership for Prevention, and United Health Foundation put out the Hank rankings, and I'm glad, we're really excited that you've moved up to 35. There are other states that have done so, including Vermont, which is now #1, which did not start at #1, but they've moved up the rankings. And focus and action and getting people engaged is the way to do that. Now, as you know, some want to go backward. There have been many attempts to dismantle the law, and there will continue to be attempts. The Public Health Prevention Fund has been attacked under many guise, and we think we're going to have to respond very vigorously to those activities. I have some predictions for, I go to 2015 because 2014 is kind of the year everything kicks in. I personally think the legislative and legal actions will fail directly. Okay? Doesn't mean there won't be any changes, but I think the more onerous efforts will fail. But they're going to slow the heck down of lots of things and lots of implementations indirectly, because people, because of the unsure nature of it, will kind of lay back, which I think is a mistake. I think we should actively and vigorously implement this law, because the problems aren't going to go away. I think that because of some of these problems, that the chronic disease rates will continue to rapidly increase, costs will not be optimized. That's my fudge way of saying I don't know if they're going to go up, how vigorously they're going to go up. But this is not a problem that we can continue to bury our heads in the sand over. If you think the bank crisis and the housing crisis were a problem, has anyone in this room been in a community where the hospital closed abruptly? We're there. We're there. We're there. And I got to tell you, if you think those two crises were bad, you wait until we have a health care crisis, where hospitals start closing all over this country, and providers find out that they can no longer take care of their patients, and they rapidly begin to get out of the business. We've got a crisis coming in this country on health care that we need to get our hands around very, very quickly. You know, at the end of the day, whatever happens, we're still going to have our core responsibilities. We're still going to have to make sure that the water is safe to drink, that the air is safe to breathe, and the food is safe to eat. That's not going to go away even if this law went away. This law helps us and empowers us to do many of these things as we go forward. But these core responsibilities aren't going to go away, and we're going to have to do them, unless we're prepared to get up every morning and boil our own water. It's not going to change. Now, one of the things APHA is doing is we're having a mid-year meeting on health reform. So this is my one commercial interruption for June 23rd and 25th in Chicago. Very much focused on health reform through the lens of the public health community. We felt that there's going to be lots of meetings on health reform. We thought that it needed to be one through our own lens, one that we can sit down and talk about things other than coverage. And we'll talk a little bit about coverage, but other than coverage. Share lessons learned about how we're transforming our public health systems, and figure out how we can get our hands around this big animal that we have called health reform. And with that, I'll stop and be happy to take any questions that you might have.